Good evening, all. We're happy to welcome you here in this our cardiothoracic imaging webinar. It's an honor for us, Philips, to support and to collaborate with PAARS regarding the educational activities of the PAARS. So let me introduce our panelists here. It's myself, I'm Dr. Ahmed Sultan. I'm responsible for the MRI for Philips for North Africa. We have Professor Dr. Osama Zain, head of radiology department in military, and Professor Dr. Ahmed Samir, professor of early diagnosis in Ain Shams University, and Dr. Mesameh is the application specialist for MRI Philips North Africa. From here, I would like to hand over to Dr. Osama Zain to introduce our speakers.
Thanks, Dr. Ahmed. Good evening, everybody. I would like to enjoy our webinar. It will be the first webinar 2025, but it will not be the last one. We plan to have a webinar each month to specific talk and specific subject. Today we will start with Professor Dr. Ahmed Ibrahim Samir, Professor of Radio Diagnosis at Ain Shams University. His talk will be about what clinicians expect from cardiac exams. And then Dr. Mesameh, which is a clinical application specialist of Philips Middle East and Africa. He will talk about scanning tips, post-processing demo. And finally, we will be with Mr. Naif, clinical application manager at clinical application manager. And we'll talk about enrollment of the cardiac education course for audience. Please, Dr. Ahmed, floor for you.
Thank you very much, Dr. Osama. Thank you very much, Dr. Ahmed Sultan, and thanks for Philips, and thanks for Egyptian Society of Nuclear Medicine and Radiology for allowing me and giving me this pleasure to share my experience in how the clinician wants technician to perform a cardiac MRI examination. So let me share, first of all, my lecture. I hope clear for everyone. So I will be giving a sort of introduction for what clinician expects from a cardiac technician regarding a cardiac MRI examination. And I will be speaking from a perspective of a doctor. And Mr. Mesameh will be repeating a lot of points in my lecture from another point of view, more clinical and more applied, especially regarding workstations. So why cardiovascular imaging is so powerful in 2025? Simply because now in 2025, we have still a lot of cardiovascular diseases, and still cardiovascular disease is the #1 killer. That's why you had a big boom as far as regard CT machine and as far as regard MRI machine. And this boom started more than 20 years ago and still is in evolving a lot. And we're still getting marvelous new CT machine and new MR machine. And my focus today will be on MR examination, cardiac MRI examination, and how to perform an ideal cardiac MRI examination. I will be starting from the scratch, really from basics, and I will be gradually progressing all through my lecture till the end. And as you all know, a cardiac MRI examination is one of the most, I will not say complex, but one of the most complete examination that should be performed by a technician, and he should have a great experience. And a cardiac MRI examination is a combined ECG gated and respiratory gated examination. So ECG gating, meaning we are putting the ECG leads on the chest of the patient, and respiratory gated, we're putting a bullet, or we're controlling the respiration of the patient by putting a sensor over his abdominal region. Starting with respiratory gating, as you can see here, we are controlling and we are acquiring the image during the ECG, during the end systolic region, and we are combining that with an expiratory phase during which we try to combine the acquisition of the image in best expiratory phase and in best end-systolic phase of the ECG. So this is the first part, the respiratory gated. And regarding the ECG, I would like to highlight some points that are very important. This is a normal ECG outside the magnet, and this is the QRS complex, and this is the QRS, and this is what we call the RR interval. But when we put a patient inside of a magnet, you can see that the ECG is totally distorted. And actually, without going into complex physics, this is due to what we call magnetohydrodynamic effect. And to make it simple, the flow within the aorta is higher and speedier and higher speed within the aorta when the patient is inside the magnet. And this will lead to superposition of T wave and QRS waves together, giving us these bizarre waves. And the solution that was found by manufacturers of cardiac MRI in the whole world was to use what we call a VCG. So that's why you are not using the term ECG, but VCG when we're speaking of a cardiac MRI. And the idea of the VCG is vector cardiac gating imaging, is that we are acquiring in 3 dimensions, in all directions, X, Y, Z, Y, and Z, we are acquiring in all directions the ECG so that to get what we call a VCG flow, as you can see. So it is not exactly as the normal ECG that we are used to see in our daily work as cardiologists or cardioradiologists, but it is a different way adapted especially for the cardiac MRI examination. And here it's very important to point why we could have a poor VCG waves, as in this case. Usually it doesn't go outside these 4 reasons. Dry skin, if the skin of the patient wasn't shaved properly, if it is too dry, this wouldn't allow the ECG leads to be transmitting a good signal. If the patient is too obese, if there is obstructive lung disease and a lot of air around the heart, okay, if there is pericardial effusion, as you can see here, or obese patient, all these factors can affect the VCG signal. So this is very important, starting an examination to start with a proper VCG signal with a proper respiratory gating examination. If you're going to enter into the world of cardiac MRI, should just be aware that we have some bizarre names like prospective acquisition and retrospective acquisition. To make it very, very simple, prospective acquisitions is the idea is to acquire a signal only at the end-systolic phase of any RR interval of the ECG. So, and we are using this prospective acquisition, which we also call RR triggered data acquisition in localizer, in black blot images, in early gadolinium enhancement cuts, in late gadolinium enhancement cut, in SARE, in T1 Scout, T2 Star, and T1, T2, and T2 Map. What about the retrospective acquisition? And actually, prospective and retrospective are also used in CT, by the way. And here it's the same idea in MRI. We're using retrospective acquisition, which is a continuous data acquisition. So we are acquiring the signal all through the cycle when we want something with a lot of data and very rapid acquisition. So to make it simple for you to remember, if you're doing some cine images, so it's a live video of the heart, or if you're searching for flow across aorta, mitral valve, tricuspid valve, these images, we need a lot of data, we need very rapid images, so that's why we are using, in these cases, retrospective. And all the rest is prospective. This is to make it very, very simple. Okay. This is an ideal general cardiac MRI protocol. This is the dream of any cardioradiologist, is to have always a comprehensive, complete examination. And I will be repeating these slides differently, several times during my lecture, and showing you each time what the cardiologist and what the cardioradiologist is looking for and in which disease and how to adapt this protocol. But in general, the protocol is some black blood images in axial, maybe you can add some coronal views, then some white blood images, and we are speaking of white blood. Why? Because these images are T2 based, because the blood is white, as you can see. And here we are looking for the 2 key images in the MRI, the 4-chamber view and the 2-chamber view. And I will be repeating that a lot and explaining a lot. And we can add plus or minus the virtual, vertical long axis images. If we are looking or suspecting for hemorrhage, we can add some T2 star imaging. If we are, and we must in all our protocol be adding T2 fat suppression, which is a very sensible sequence for edema. It is the corresponding, and it is corresponding to the flare images in brain or in neuroimaging. Then we inject contrast, what we call early gadolinium or dynamic acquisition, and we acquire our images, what we call the late gadolinium enhancement, and it's called late or because it is acquired usually 8 to 10 minutes after the injection of contrast in the dynamic, as you can see. And then we get this type of late gadolinium enhancement. Usually these images, we try to acquire them in short axis and 4-chamber view. Remember, these are the key images for a successful cardiac MRI. Once you have a good short axis and a good 4-chamber view, everything is okay. Then we can add some physiological studies, physiological information, like the T1 mapping and the T2 mapping and the ECV cuts, which can be helpful a lot for proper and more informative examination regarding a cardiac patient. So what about injection of contrast? We have two patterns of enhancement, and you must be aware of the pattern of enhancement. It's either ischemic or non-ischemic. Ischemic pattern of enhancement, it is an abnormal enhancement starting from inside of the heart and going also if it is progressive, to involve the whole thickness of the heart. So we're speaking of subendocardial infarction if we have enhancement from inside, and if we have the whole thickness of the heart involved, we're speaking of a transmural infarction. This is the most common pattern. This is the most commonly demanded examination. So we are speaking of patient coming for ischemia, patient coming for assessment of viability. This is the biggest amount of patient we'll be dealing with. And it's very important for all of us to be aware of the pattern of enhancement, what we call subendocardial and transmural infarction. We have some other pattern of enhancement. So this is an example, for example, in A of a subendocardial starting good prognostic infarction. This is a bad prognostic infarction. In B, this is a transmural infarction. A and B are the typical ischemic pattern. We have some other pattern of enhancement, for example, patchy enhancement. This we see it in cases of sarcoidosis. Mid-wall enhancement, as you can see here, this is typical for myocarditis. Bizarre pattern of enhancement taking the whole endomyocardium in cases of amyloidosis. And believe me, we have a lot of cases of amyloidosis. But before going into depth, just a small note so that you all know what is the standard and the gold standard now. And the gold standard in 2025 is not for going in cases of ischemia for a nuclear scan, but is going for cardiac MRI. Simply because cardiac MRI is superior in resolution, as you can see, much superior resolution compared to nuclear scan. It has no radiation, and it has no false positive or false negative findings, as you can see in SPECT examination. So this is very important from this slide. What I want to say is that cardiac MRI is the gold standard for assessment of the myocardium in 2025 and assessment of viability for in cases of ischemia. A very important term and a very important point that must be very clear for everyone is what we call the lock-locker sequence or the T1 scout sequence. So if we come back to the protocol, the general protocol, you notice here we injected contrast, and then we are to perform what we call a lock-locker or T1 scout sequence. And the idea from this sequence is to get the darker possible myocardium. So let's go back to our sequence. So as you can see, a normal myocardium is always black. Any abnormal myocardium, it means that the myocardium gets infiltrated by contrast, is getting white, as you can see. And this is an example of a subendocardial infarction. To get such a nice idea, we want to see the contrast very nicely against a very black myocardium. So the idea is to perform this sequence lock-locker before acquiring the late gadolinium enhancement cuts after 8 minutes. And why we are doing this lock-locker sequence? because we want to get a proper time. And this time, as you can see, is written on your sequence. So in this case, for example, 286 millisecond, in this sequence, and in this timing of 286 millisecond, we have a very black myocardium. If you inject contrast and there is an abnormality within the myocardium, you will properly see the enhancement in this timing. So you take this time and you put it in your late gadolinium enhancement cut, and that's the way. It's okay like that? I think it's an internet problem. Okay. And if, for example, you take a bad time, like this time in which the myocardium is gray or the myocardium is too white, you won't be able to properly see the contrast in such timing. So the locker is the key of your success of your post-contrast phase in your cardiac MRI examination. You have to acquire this locker time and choose the proper time and insert it within your late gadolinium enhancement sequence to have a successful late gadolinium enhancement. Usually everything gets smooth and everything is okay in such situation, except in one disease, and this disease is called amyloidosis, and it is not so rare. It's much more common than we expect. We had 20 cases of amyloidosis this year, which is a very big number, especially that amyloidosis is presumed to be a very rare disease, which is not so rare as expected. And in such disease, we have some greasy material infiltrating the whole myocardium. That's why the pattern of enhancement is very bizarre. We call it zebra pattern, ground glass pattern of enhancement. And usually to get the proper locker time, it is very difficult in such cases. And you have to repeat your locker time several times, and you have to increase the number that you are using in your late gadolinium enhancement cut, because with this greasy material infiltrating the myocardium, it's very difficult to adjust your nulling time. We're speaking of a nulling time. This is the nulling time, is the point at which the myocardium is the blackest, is the more dark possible. And in cases of amyloidosis, it's a little tricky. So that's why I wanted to share this slide with you. Coming to the second topic, the clinicians are sending patients for a cardiac MRI examination are the cardiomyopathies in general. I will not go into this complex classification of the European Society and the American Society for Cardiomyopathy, but the simplest classification actually is the classification proposed by the WHO. And we're thinking of primary cardiomyopathies affecting the myocardium. Is the sound okay for everyone? Yes. Is the sound okay? Should I continue? Okay. So if we're speaking of primary cardiomyopathies, the most famous cardiomyopathy you will hear a lot about are the hypertrophic obstructive or non-obstructive cardiomyopathy or the dilated cardiomyopathies. These are very famous. Very rare cardiomyopathies like arrhythmogenic cardiomyopathy, which is a type of cardiomyopathy in which the patient presents with some electricity problem and some arrhythmia, and non-compaction are very, very, very rare. The secondary cardiomyopathies are secondary to ischemia, secondary to an infiltrative disease like amyloidosis, for example. These are the most common. So the clinician will be sharing and asking for a cardiac MRI examination for 3 conditions: for an ischemic disease, for cardiomyopathies, and for cardiac tumors. These are the big 3 topics for which a clinician will be sending an examination. Now, just a small slide to make you remember, if you have this option on your cardiac MRI machine, what we call the mapping sequences. So we have some mapping sequences that are the equivalent of spectroscopy in brain and neuroimaging. We call them the T1 mapping, which is very sensible for fibrosis. So any starting fibrosis, the T1 mapping is very, very sensible for detection of fibrosis. And we have the T2 mapping, which is very sensible for edema, like the T2 fat suppression exactly. And lastly, the third, number 3 star in the physiological indicators in cardiac MRI is the ECV, or the extracellular volume, which is the calculated number that we can get from the T1 mapping images. And this number should be around 26. If it is higher, it means that there is something abnormal. So these three physiological stars, T1 and T2 mapping and ECB, are the equivalent of spectroscopy and help a lot your clinician in and your cardiac radiologist to reach a proper diagnosis. This was the first part of my lecture for the introduction. Going to basic cardiac MRI, what we should be aware of. Very rapidly, as you all know, the heart is receiving blood from the whole body through the superior vena cava and the inferior vena cava, coming to the right atrium, passing through the tricuspid valve to the right ventricle, and then going to the pulmonary artery and going to the right and left pulmonary artery. Then the blood is returning, the oxygenated blood is returning via the pulmonary veins through the left atrium, through the mitral valve, through the left ventricle, through the aorta, and then going oxygenated into the whole body. That's why the color is in red. This is what we call the long axis of the heart, and this is what we call the short axis of the heart. These terms are very important, and we should be all aware of these terms. You should be aware as well of the blood supply of the heart. This is very important. So we have three coronaries supplying the cardiac muscle. The left main, which is bifurcating into LED and LCX. The LED is the very important vessel, and the LCX is a smaller branch. And on the right side, it is called right coronary artery. So if we are cutting the heart into slice, the apical portion is supplied anteriorly. The inferior segments in red are supplied by the right coronary artery. So the right coronary artery is giving blood supply to the myocardium and to the left ventricle. Then we have the LCX supplying the lateral aspect of the heart, as you can see in blue. And lastly, the most important artery, the LED, is supplying the apex of the heart, the anterior and the septal walls. This blood supply distribution is very, very important because it allows you to recognize if the patient is an ischemic patient or if the patient is coming with another pathology like myocarditis or sarcoidosis or other pathology. Because when you have an ischemic event or you have a problem in viability or you have some scarring, it will always be following a typical territory, exactly like in the brain when you are looking at an infarction following the middle cerebral artery or the anterior cerebral artery or the posterior cerebral artery. It's the same idea. If we have an ischemic event, especially usually it affects the LED, it will be taking the anterior or the septal or both of them, and so on. This is very, very important to be aware of the blood supply of the heart. Coming to some names and notes that are very important. This is an example of a short axis cut. We can name it SA, short axis. This is a 4-chamber view, and this is the vertical long axis view. These terms are very important, and you should be all aware, and you should know it a lot. I will be repeating that several times to be sure that everyone know it by heart. This is the vertical long axis. So this is direction of acquisition, and this is the cine white blood vertical long axis, left atrium, left ventricle, and notice here we can see the mitral valve very nicely. Again, this is the 4-chamber view. This is the way of acquisition, and this is the image we get when we are asked to perform a 4-chamber view. So if I tell you I want a 4-chamber view, this is the 4-chamber view we want. Left atrium, left ventricle, mitral valve in between, and then right atrium, right ventricle with tricuspid valve in between. If we are asked for what we call a short axis view, these are images perpendicular to the 4-chamber view that we acquired. So these are slides perpendicular to the long axis of the heart, and this is the right ventricle and left ventricle. Notice that the left ventricle has a very thick wall, which is characteristic, and the right ventricle has a very thin wall, and this is the moderator band, which is a characteristic feature of the right ventricle. After you acquire your short axis, if you perform some perpendicular slides on your 4-chamber view coming from the apex, still the lower portion of the mitral valve, and you cover the whole heart, these are what we call the functional images. By taking these whole images, you can give your patient a full echo report with all the data that the patient can acquire from an echo examination, including end-diastolic volume, end-systolic volume, cardiac output, ejection fraction, all that can be acquired from these images if they are acquired nicely, meaning that your images must be perpendicular to the long axis of the four-chamber view. Your four-chamber view must be a true four-chamber view, and you must not acquire sequences or cuts above the mitral valve, and you must not acquire images after the apex of the heart. This is very important because these images are the base on which the whole post-processing will be performed, as will be explained by Mr. Misameh in the next lecture. Regarding artifacts, it's very important for you to be performing a good shimming before starting your cardiac MRI. And in some machine, it has to be done manually. In other machine, it is automatically done. But shimming sometimes is needed, and you should do it manually for preventing some artifact. This would appear as a subendocardial infarction. That actually, this is what we call an off-resonance artifact. Okay, why? Because the shimming wasn't performed well. Another example, this appear as a thrombus or some malignant mass within the myocardium. After proper shimming, you can see that there was nothing, and actually the flow in white, in the thinny white blood, is perfect after shimming. So the shimming is very important in all examination. After that, very important that your patient is properly prepared. So you have the famous MRI checklist. You must check that he has nothing metallic. He has a pacemaker that is not compatible with the cardiac MRI field. He has to empty his bladder. You have to double check with your doctor if the kidney functions are okay. You have to properly shave the skin so that the ECG, the MR compatible ECG leads are well sticking and giving us a good signal. You have to train the patient for what we call end expiration, and your coil must be ready, and if possible, put some hearing plugs in the ear of your patient so that he's not, because the cardiac MRI examination is a lengthy examination varying in time between 30 minutes and 45 minutes. So it's very important to help him support this lengthy examination, especially that he is in stress. Starting your acquisition, usually we would like to put a shim volume box over the heart to be sure to get the maximum amount of signal from the field of view, from the cardiac field of view. Then you acquire some axial images, like in CT exactly. Then you get a vertical long axis line passing from the apex to the mid portion of the mitral valve, giving you what we call a VLA, vertical long axis image. So this image will be giving us this image. And after acquiring some an image passing from the apex again through the mitral valve, you will get what we call a pseudo four-chamber. This is not a true four-chamber view that we want. We are looking for true chamber view and short axis, like I've explained several times, and this is very important. This is the pseudo four-chamber view. From this pseudo four-chamber view, we'll get a perpendicular cut, giving us this short axis view, and from this short axis view you will pass through the apex of the right ventricle, so the mid portion of the left ventricle, and you will get what we call the true four-chamber view. It's very important to acquire this true four-chamber view. It's very important to be acquainted with the anatomy and not to be getting some images like that at pseudo four-chamber view and continuing your examination on this type of images, because if you continue on this type of images, the whole rest of the examination would be wrong. The calculation of the function will be wrong, and even the whole planes of short axis and four-chamber view will be wrong, and will let your cardiac radiology doctor completely mad, not able to properly assess the case. So to resume, we start by some black blood images, then we go for short axis view, four-chamber view, plus or minus vertical long axis. Okay, we must take care not to align our cuts on the pseudo four-chamber view, but you get your short axis view from the four-chamber view, and from this four-chamber view, then you can calculate with a multiple short axis from the apex to the base. You can calculate the LV function, and according to the demand, and according to the situation, and according to the patient presentation, you will be asked to perform some LVOT view, RVOT view, Q flow on aorta and pulmonary, and don't worry, I will explain everything in detail. I think we're okay in time. So This is the type of images, the axial black blood images we start with, short axis, axial cuts from the base of the neck, still the diaphragm. From these images, when we get the heart, we acquire this yellow line passing, as we have said. I'm repeating again because I want to be sure that everyone is well aware of the positions and the names. And from this yellow line passing from the apex of the heart to the mid portion of the mitral valve, you get your VLA, vertical long axis. From this vertical long axis, you acquire another time a line passing through the mid portion of the mitral valve to the apex to get what we call the pseudo four-chamber view. From this pseudo four-chamber view, you get the perpendicular cuts on the interventricular septum to get what we call the short axis with the LV and the RV, as you can see. From this short axis view, if you acquire a line passing through the apex of the right ventricle and the mid portion of the left ventricle, you will get what we call the four-chamber view. So the key images again and again for a successful cardiac MRI examination are the short axis view and the four-chamber view, very crucial to a successful cardiac MRI examination. From that, if you have this good short axis view and four-chamber view, you can then calculate the LV function, taking cuts, as we have said, from the apex of the heart, maybe 6 to 7 to 8 cuts, as you can see here, till the base of the mitral valve, just below the mitral valve. And from these images, you will calculate the whole echo portion of the examination, the whole echo data of the examination, which is very accurate, by the way. And a lot of studies were performed comparing echo and MRI, and MR was found to be superior and much more, not operator dependent, so repeatable, and the data is very accurate, from what we get from our cardiac MRI examination. This was the second part of my lecture. Now I'm moving to a slightly more advanced last portion of my lecture, speaking of some advanced cardiac MRI sequences that may be requested according to the pathology and the presentation of the patient. So if you are asked to get some images on the heart, on the aortic arch, simply you go back to your black blood axial cuts. When you see the aortic arch, you draw a line perpendicular to the ascending aorta and descending aorta, passing from the middle, and you will get this marvelous black blood arch. And this image is very important in some cases. And you can acquire this image in black blood or in white blood cine according to the demand and according to the demand of your referring doctor. If you want more information on the root of the aorta, what we call the LVOT, the left ventricular outflow tract, which is the region below the aortic valve and going upward, we call it the LVOT. So you may be demanded to acquire what we call an LVOT or a three-chamber view. Why three-chamber view? Because we have left ventricle, left atrium, and aorta. So it's like if we had three-chamber. So we'll be asked a lot to acquire this LVOT sequence, and this LVOT sequence is mainly demanded in cases of hypertrophic cardiomyopathy, in which we have a hypertrophy of the muscle, and we want to see if the origin of the LVOT and aorta are closed or not, if the blood is properly passing through the left ventricle to the aorta during the systole. And this image is very important. And any case of hypertrophic cardiomyopathy, if you don't do it, if you don't perform a three-chamber view in it, then the examination is lost. So this is a crucial step. All cases of aortic stenosis and aortic regurg, again, as well, you must be performing this three-chamber view. From this chamber view, three-chamber view, if you get it, you can acquire what we call the Q flow, which is amount of blood. You can calculate the exact amount of blood passing through the aorta. What is this Q flow? Q flow is actually a phase contrast sequence, like the phase contrast sequence we are using in neuro in cases of CSF fluometry, for example. It's the same idea. We want to calculate the amount of blood passing from the left ventricle to the aorta. So we get this three-chamber view, and from this three-chamber view, we can put our cursor just above the level of the aortic valve, as you can see in this three-chamber view and this LVOT view, and you can calculate what we call the QS flow, or the systemic flow across the aorta, and you have to adjust your VINC or the speed of your acquisition between 150 and 200 centimeters per second to get a proper aortic flow or a proper systemic flow, or what we call the QS flow. You may be asked to acquire what we call the right ventricular outflow tract. So here we are not looking for the aorta, but we are looking at the pulmonary, especially in some congenital cases like Fallot disease or arrhythmogenic right ventricular dysplasia, which is very rare, as we have said. And here the idea is to get your axial cuts, get the main pulmonary artery bifurcating into right and left pulmonary, and put your line perpendicular on the flow on the main pulmonary artery. This is the aorta ascending and descending, and this is the main pulmonary artery, and acquiring these images to get what we call this RVOT flow, which is RVOT tract outflow image. We're giving you, if you put a perpendicular line through the RVOT, you will get this pulmonary outflow tract, which is the Q or the key image if you want to calculate the flow across of the pulmonary artery. So in this case, it will be called QP flow, which is the flow across the pulmonary circulation, across the pulmonary artery. And again, you have to adjust your vein in such cases, but it is lower than the aorta, so you adjust it around 100 centimeters per second, and you will get these two images, which are typical. This image is called the magnitude image, and this is the phase image. And you can see here very nicely the valves of the pulmonary artery. So I know I'm giving a lot of data, so try to resume things very rapidly. So you usually start by some axial cuts over the whole chest. From it, we acquire the vertical long axis from this red line. From perpendicular line over the myocardium, you get a short axis. From the short axis, if you pass from the mid left ventricle to the apex of the right ventricle, you get this four-chamber view. From this four-chamber view, you can get a lot of short axis view. From it perpendicularly, you can get this three-chamber view or the LVOT view. You can see the aorta very nicely. And from the four-chamber view, if you acquire a line passing through the apex of the heart and the mid-mitral valve, you can get what we call a vertical long axis, only showing the left axis of the heart with the left atrium and the left ventricle. And from the three-chamber view, you can get the LVOT, as you can see here, view. And if you acquire some perpendicular cuts over the left ventricle, you can get some short axis cine view from which we can calculate the function of the heart. This is a simplified way of planning the left ventricle very rapidly. If you're asked to perform, I'm repeating again, the QP flow, so I want you to know the term QP flow or pulmonary flow, or the flow across the pulmonary valve. This is the way of acquisition, as we have said, passing through the main pulmonary artery, and then we'll get this the whole pulmonary artery with the RVOT region. And if you get a perpendicular plane on it, you will get this coronal MPA view, from which if you put your line of acquisition just above the level of the pulmonary artery, you will get your magnitude view and you'll get your QP flow. This is the QP flow, and this is the way of acquiring the aortic flow or the systemic flow. That's why we call it QS, Q systemic, S for systemic, and this is the way of acquisition. And again, this is the type of image, the proper adjusted images for getting a QP and a QS flow. And it's very important to be acquiring above the level of the valve, as you can see, and your line of acquisition must be exactly perpendicular to the aorta. And this is very important. That's why you must acquire it in two views, in the three-chamber view and the LVOT views, because otherwise the calculation will be wrong. So to make it short, this is an example of an updated cardiac adult MRI protocol. So what we are asked to do, some black blood images, some white blood images, four-chamber view and short axis view. T2 fat suppression short axis are a must for detection of edema, and edema is very important, as you can see in some cases of acute infarction or in cases of myocarditis. Then from these 4-chamber views, we can acquire a lot of short axis view and calculate and get the LV function images or the echo examination. Then we inject the contrast, as we have said. We wait 8 minutes. We acquire our locker image. We choose which is the better timing where the myocardium is completely dark. In this case, for example, it's 250, as you can see. And then we acquire our late gadolinium enhancement. Plus or minus, you can add T1 and T2 mapping in short axis manner. This is the best complete MRI protocol. In some cases, like for cases of hypertrophic cardiomyopathy, in which there is obstruction of the LVOT, you will be asked to add the 3-chamber view, this one, to be capable of properly assessing the LVOT tract and the aorta, and to be sure that the flow is okay or not and passing or not, because we have 2 types of hypertrophic cardiomyopathy, either obstructive or non-obstructive. The idea is to answer the question. The clinician wants to know if it is obstructive or not, and whether he needs to perform an operation to this hypertrophied region if present or not. Otherwise, the rest of the protocol is the same. We can go for pediatric MRI examination, especially in children that are cooperative above 6 years. Usually it's much easier. And in pediatric population, it's not obligatory to perform a post-contrast enhancement cut, but it's very important to perform the QPQS. And usually the ratio between the aortic flow and the systemic flow and the pulmonary flow is 1:1. And in cases in pediatric population, the idea is to see if there is abnormal shunting, abnormal communication of blood between the left side of the heart and the right side of the heart. So this is an example of a good aortic Q flow, and this is an example of a good pulmonary flow, as you can see, well performed, and you have a very nice ascending flow image in white and a very nice descending black image. And this is an example of a bad QPQS image, and you can see some aliasing. This means that your image is not good. Why? Because the amount or the venk you have chosen is not enough, so it has to be increased. I will be finishing. These are my last slides. As you can see here, this is an example of a follow-up for a patient with Fallot disease. This patient had pulmonary stenosis, and this patient has had a pulmonary dilatation of the pulmonary artery. And you can see that there is, in his QPQS ratio, there is some reflux of blood in the pulmonary valve. And this is the question the pediatrician wants to know: the amount of reflux, the amount of incompetence of the valve that was dilated after the severe pulmonary stenosis, and here the QPQS was 1.5 to 1. So you can get very accurate data and very accurate information for the cases of Fallot. So this is the protocol for an ideal protocol for pediatric population. Not very important to inject contrast, but very important to add the 3-chamber view and the pulmonary view, and from which you will calculate the QPQS with the pulmonary and the aortic flow. Lastly, in 2025, yes, we can perform chest MRI. Yes, there is an examination called a chest MRI. The advantage, it has no radiation, it has a very high spatial resolution, it is reproducible, and we can see the MRI, you can see through an MRI, you can see the pulmonary arteries very nice. And this is a very nice examination to be performed in patients having, for example, very high serum creatinine or pregnant females. You can perform this chest MRI protocol to exclude the presence of pulmonary embolism. There is no need to inject contrast in such cases. And again, the idea is to perform an ECG-gated and a respiratory-gated examination, just axial and coronal black blood, axial and coronal white blood without contrast, and you can answer the question if there is occlusion of the pulmonary artery by embolism. So this is a very updated protocol that I like to speak about. Lastly, T1 and T2 mapping are very, very important sequences that should be added into all our examination. T1 mapping is sensible for fibrosis. T2 mapping is sensible for edema. And the idea to finish my lecture is to speak a little about MRI 4D flow, which is a very important subject in all recent conferences now. And the idea is to combine a magnitude image with three phases direction, three differences volumes in different direction, right to left, anterior posterior, and superior anterior, and you can get this marvelous 4D flow, which are very informative about the flow and are better than the QP-QS ratio, because we can get all the calculation forward and reverse and regurgitation and fraction, and some additional information like the wall shear stress images and the pressure difference and the kinetic energy loss. So a very hot topic and very important topic that, and to finish my lecture, this topic, this 4D flow, is very important for this very important and last publication by Professor Magdi Yaoub in Egypt, who is speaking of now inserting living valves within the heart. So a baby now with a completely broken valve, we can put him this type of mesh valves, and then on it will grow normally a neo valve. So this is the future, and maybe he will take a Nobel for this paper. This publication is very recent, and for such cases, we'll be following these cases with 4D flow. It will be mandatory. Again, thank you very much. Don't forget healthy life, healthy eating. This is the best way for prevention against ischemic heart disease and coronary artery disease. And thank you very much.
Thanks, Professor Ahmed, for your nice talk with a lot of knowledge in a very short time. I have a lot of knowledge for this talk, and I think that will be at the end of our webinar. And now Dr. Musameh will show us how we can get this image machine and from the technique. Go, please, Dr. Musameh.
His mic is down.
Mic, Musameh, please. Your mic is muted. Unmute your mic, please.
اوكي تمام كده الصوت.
Yes, it's okay. It's okay.
تمام. الشاشة واضحة دلوقتي؟ كده كويس؟ تمام. Okay, my name is Musameh Mohammed Nadi. We'll start with patient preparation and positioning. In this talk, I will try to concentrate on our Philips software, how to obtain our sequences from library, and most important parameters, and finally the post-processing steps. We'll start with patient preparation and position. You can scan this QR code containing a lot of educational material from Philips, recently released. The patient preparation and positioning is the most important step in obtaining a good cardiac MRI. As Professor Dr. Ahmed said, we must get the patient feel comfort and put the VCG electrodes tightly, and of course put the receiving coils to start our examination. This is a short video containing this patient preparation and positioning steps. هنبدأ أول حاجة خطوة البيشنت بريبريشن بوزيشن. بنركب الإلكترودات بتاعتنا 4 إلكترود. سوري. We will start to fix our 4 electrodes. The first one above the sternum, and the second at the xiphoid process, and the third one at the left side of the chest. The fourth one will be beneath the chest, exactly at this position.
This is the arrangement of our cardiac electrodes. We have to choose a channel directly. And the most important part here to put this wireless module away of our imaging volume because it causes artifact. I will give you example for this. We have to train our patient for the brace hold. If the patient move our electrodes, we can fix them either by straps. This unit mustn't be directly contacted to the patient's skin, and they didn't put in the imaging volume. This arm support for patient safety and comfort. Okay, this step is to make sure that our machines can detect the VCG signal or cardiac signal, so we can start our imaging triggering on cardiac motion. This is most important step. Before putting our receiving coil, we have to make calibration to make sure that the positioning of the electrodes is good, or we have a good signal, and that the triggering quality is good. We choose the channel and activate manual calibration, then start calibration. It will monitor the cardiac VCG for 15 milliseconds. The purpose of this step is to ensure good signal or good strength, good signal strength from the electrodes, and good triggering quality. If we have problem with the strength, we can relocate the electrodes to get more signal or more powerful signal from the patient. The last step is to put our anterior coil or our receiving cardiac coil. After we make good patient preparation and positioning, we will go to our software. This is Philips software. بسم الله الرحمن الرحيم. This is the total cardiac MRI protocol. It seems a very long protocol, but we will separate it into separate modules. First module is localization and functional CINI. Second one, and Q flow and tissue characterization, as you see here. We will start from this protocols, from these modules, one by one, how to obtain it from Philips library and what is the important parameters we can modify. We start with our survey. The most important step in cardiac MRI is to obtain a good survey. We have most common 5 survey we use: axial, sagittal, coronal, chest, and one long axis survey, and the other one is short axis survey. It's 5 surveys. This is where we obtain our surveys. This is the general survey, only to ensure the patient is at the center. Then the other one is single shot survey or 2D, which is used to give us a good anatomy and extracardiac morphology. The function module or CINI modules, we can obtain in heart, CINI, function CINI. We have here a lot of options. We'll highlight the most important. The first one is the common CINI or balanced CINI. The second two important one is the single shot, which we can use in patient with poor breath hold or arrhythmia, simple form of arrhythmia. The single shot can give us one slice, 30 phases in about 3 seconds or 2 seconds, and it's available from our old Achieva systems till now, till Ambition and 5300. It's called CINI single shot. The first one, as I told you, is the routine with patient, with good patient, and with can hold his breath. If we make it a free breathing for the patient with breath hold, it will take a lot of time. We increase the NSA, it will take a lot of time. So a lot of times we use this single shot strategy in patient with poor breath hold or with arrhythmia. This one is TFE breath hold, is the same as the first one with balanced, but this has a good resistant against metal artifacts. If we have a patient with pacemaker or metal artifact, we can use this one, TFE breath hold. The first one is the real time. We can use it for just monitoring the cardiac function. We cannot make cardiac functional analysis with this because it is not cardiac gated. So we have now 4 important one, the BTFE, which routine CINI, a single shot for poor breath hold and arrhythmia, and the TFE for metal artifact, and the fourth one is real time, which is used when we can't get a good VCG signal. We'll go now to the third module, Q flow. Obtaining flow the same, in the same folder of CINI. We have breath hold and free breathing. We can modify both of them to be in plane or through plane. We will discuss it later. The fourth module is the tissue characterization module without contrast, including T1, T2 stair, and T1 mapping, T2 mapping, T2 star mapping. I will show you the location, how to obtain it. Okay, the most important tip here, if you are scanning a short axis stair, we have to take the stair from morphology, black blood, short axis folder, not from the long axis folder, because each folder contains unoptimized parameters according to the orientation of the scan. So if we need, for example, 4-chamber stair, we have to take our stair from the long axis or LA black blood folder If we need it as a short axis, we must take it from black blood short axis folder. This folder contains T1, T2 stair, all the black blood images. The same in the short axis and the long axis. To obtain cardiac mapping, also in cardiac mapping, we have T1 and native and T1 enhancer. We have to choose the T1 native without contrast, and the other one is after post contrast. The most important tip here also, we have to fix the time or the delayed time after the contrast injection. For example, 10 minutes or 15 minutes according to site reference, but we have to fix this time for the same machine. Not to scan, for example, 10 patients with 10 minutes delay, T1 mapping, and the other 10 patients with 15 minutes as a delay. We have to fix this time. The post-contrast characterization module, we can obtain it either dynamic is the temporal enhancement folder, the look looker or TI scout from look looker folder, and the delayed enhancement from delayed enhance folder. In the dynamic, we can choose either we need one plane, short axis, for example, or we can need multiple plane. For example, 2, 3, 4 chambers and short axis at the same time. This is the post contrast folder. Contains also the image inversion with the base. We can use it. Little press hold time with good image quality, either the 2D or the 3D one. If the patient also is poor press hold, we can use the single shot strategy. And if the patient have, for example, amyloidosis and we can get a good nulling point for the late gadolinium, we can use PAARS images, either 2D or 3D, which is more robust in delayed contrast. Okay. We will scan these modules one by one. We will start by the survey and the importance of the survey. The survey is very important in cardiac MRI. The cardiac MRI protocol is on every step in this protocol give us information, even the survey. The survey can give us a good or not good preparation of the patient. We can start examination or report. The second one can give us a good cardiac anatomy and morphology. I can take a general look for the patient. If you have pulmonary stenosis, aortic coarctation, and even aortic regurg. And the other one, the other good information we can get from survey is the extracardiac finding. This is a good example for the positioning of the wireless module for ECG. Here it is positioned in the volume we are imaging. And the other one, the other defect here, with anterior coil is not positioned on the cardiac, it's positioned on the liver. We have to repeat this survey again. After moving this part out and moving the anterior coil upward. This is a new survey. We can see the cardiac in the center. Okay. Only for preparation, we took this survey. We start our good 5 surveys, as I mentioned before. by planning axial, sagittal, and coronal chest. This green box, as Professor Dr. Ahmed said, is the shimming box. We have to adjust this box according to the volume of the heart, and it will be fixed all the other steps. We just make it on one time. Okay, this is a good example of cardiac pathology. We can detect it from the initial survey. You can see this is aortic regurg. So during the scanning of this patient, we will need to make not only aortic flow, but we will add an extra step with subaortic flow for this regurg. We can see here the cardiac morphology and the cardiac extra cardiac finding. This is a good example. We have here a thrombus or mass. We detected it from the survey. So the survey in cardiac MRI is very important to detect either cardiac pathology or non-cardiac finding. For example, this lesion at liver, we can add a dynamic liver MRI with our cardiac examination. This is a good example of right or left pulmonary disease. So to summarize this video, this is importance of our survey to obtain cardiac pathology and cardiac morphology and extra cardiac finding either in liver or on chest. اوكي نيجي بعد كده نتكلم عن This video is to demonstrate the planning of cardiac MRI. After we obtaining the three surveys, axial, sagittal, coronal, chest, we make one survey for long axis and other for short axis. This is the long axis survey and this is the short axis survey. As Professor Ahmed mentioned before, the anatomy of this short axis survey, we have this anterior wall, and this is the inferior wall, and this is the lateral wall, and this is the septal wall. The septal wall, according to the coronary supply of these segments, we can segment it as 6 segments. This anterior, inferior, anteroseptal, infroseptal, and anterolateral, infilolateral. The planning steps for this 4-chamber, 3-chamber, 2-chamber is to matching each two together. For example, anterior and inferior will blend to give us the 2 chambers view, and the other one is infrolateral with the anteroseptal, which give us 3, and the last one is anterolateral with infroseptal, which give us the 4 view. So we can imagine the line this 2, 3, 4 again counterwise. This is the 2-chamber planning. This is the 3-chamber planning. It must pass through the aortic valve. This is the 3-chamber view showing left atrium, left ventricle, and the aortic valve. The last one is the 4-chamber view, which passing through the anterolateral with infroseptal, and we try to avoid the aortic valve in the 4-chamber view. The 3-chamber view, we aim to view aortic valve, while with 4-chamber view, we have to avoid the aortic valve. But in this case, we cannot avoid because, as you see, the aortic valve is positioned between the 2 atriums. So we cannot ignore it. The last view is the short axis view. We plan it on 2-chamber and 4-chamber view. This 2 and 3 and 4. This is the short axis. As Professor Ahmed said, we have to cover the cardiac from the apex till the mitral valve. What is the most important parameters in CINI? If we have a patient cannot hold his breath, we either scan with single shot strategy, or we can increase the NSA 2 or 3, but it will increase time. The other most important parameter is the number of phases. This is where we can change our NSA. This, for example, 1 NSA, and the other is using 3 NSA. 4 view and 3 view and 2 view. For the same patient, this is for the same patient, 1 NSA, and this is 3 NSA. And the most important, as I told you, is the number of phases. If we use a very small number of phases, we will not get a good temporal resolution. While if we use a lot of number of phases, for example, 50, it will take a lot of time, so the patient will not hold his breath. It will give a motion artifact. So 30 is accepted. This is 5, and this is 30, and this is 50. So again, the most important parameters in CINI is the number of phases and the NSA. Now we will talk about the flow and the most important parameters in flow.
دلوقتي هنتكلم عن الفلو.
We have here 2 important tips for any through plane flow. We have to get across sectional flow. We have to position our plane perpendicular on 2 planes, not on 1 plane. This is the 4 through plane flow. The second important tip is to put a good velocity or wing, not too high and not too low. I will show how to modify the velocity and how to even modify the direction. For example, if I need in-plane flow for this view or this view, For example, for the four chamber view, if I need flow, in-plane flow from the mitral to the left ventricle, we will make the flow at this plane and select the flow direction to be detected from right to left. I will show now. If we have a regurg at like this example, we have to put the flow perpendicular to this regurg to quantify this regurg. This is where to put our velocity if we faced aliasing. We can see this example. We have this. White and dark is according to the direction of the flow. But aliasing means I can see white and dark at the same image. If we make it slower, you will see white and dark. We have this artifact. This white one in the aorta is the artifact. If we increase the velocity, we'll obtain it the right one, the good one. This is for the aortic valve, and this is for the subaorta. This has aliasing artifact, and the other is corrected. This is how to obtain in-plane, for example, at four-chamber view. We'll make copy image position at this by 3 point. And we'll release plane align to free rotate the field of view. And then we will select the direction where the flow need to be detected. Here in this example, we need to detect the flow from the mitral to atrium to ventricle. This example has artifact, aliasing artifact. If we need to modify, we can increase the vink from dynamic angio tab, as we mentioned before. The last module is the post contrast. The post contrast one, the most important parameter here is the time of inversion. This is the bad inversion time, and this is the good inversion time. The good inversion time, we have to see 3 colors. The myocardium is not very dark black, but we can say it as a bright black, and the fibrosis is white, and the blood is gray. This is a bad timing because we cannot differentiate between the blood pool and the subendocardial fibrosis. We cannot differentiate between the fibrosis and the blood pool. This is a good one. How to obtain it? How to obtain a good one? We choose a look looker and see which images in look looker have this timing, and insert it in contrast tab.
دلوقتي بعد ما حققنا الثورة نبتدي.
A good tip here I wanted to share with you, if we have a patient with high GFR and we injected him a little contrast dose. And when we take the looker, we cannot find a good image. And we can see the fibrosis, but we cannot see the blood pool. The good tip here is we can inject 1 or 2 centimeters of 1 or 2 milli from contrast directly in the blood to just make the blood pool a little bright. This will save the situation. 1 or 2 milli of contrast and start scanning directly after injecting them. This is where we can obtain a good time. This one was 350 and the other one is 250. We can use it in 4 chamber, 3 chamber. And short axis, of course. But what is the most important view here? In this example, if for example we have fibrosis only in the anterior wall or the inferior wall, the most important late gadolinium view after short axis is the 2 chambers. And we can add, of course, 4 and 3. But if the patient will move or cannot continue the exam, I will start with the most important long axis view post contrast. If the patient, for example, has infroseptal or anterolateral, it is in the territory of 4 chamber view. We have to add 4 chamber view just after the short axis. I hope this is clear. The most important tip also after the timing and after the injecting 1 or 2 milli of contrast, and the most important view after short axis is to remove the metal artifact in late gadolinium. We can remove this artifact by increasing bandwidth or water phase shift. We can set it to minimum. This is the effect. This is link for YouTube channel. Have a good casing box. We made it summarizing all the previous steps. Now we will go to the post-processing steps. This is our post-processing platform. We start cardiac analysis module. This cardiac analysis icon or module contains all the cardiac MRI analysis needed for the clinical use, starting from the function and ending with 3D whole heart. I will give you a good video for the post-processing. We start analysis with cardiac viewer. This cardiac viewer has 2 steps, one called labeling step and the other one is called viewing steps. The labeling step is the most important step in the post-processing, like patient preparation and positioning in scanning. Here, the labeling step is very important. This labeling step I just inform the software to be trained for each sequence to know its scan type and orientation. For example, cine. If I need to tell him this is cine, its function and orientation is short axis. If the software knowing this name and what it means here. I will translate from what I am wrote on the protocol name on the console into what the software need here, either the scan type or the orientation. According to the scan type or the orientation, the software will help me to visualize even all short axis view or all 4 chamber views. Or if I told him I need all functional view, he will collect from this step. This is, for example, short axis view. It is functional and need to be corrected to be short axis. And the good news here is the software will save this name with this setting. If we use the same protocol, we will get the same. We will not need to come to this labeling step again. In the old days, we have to select end diastolic and end systolic manually. And start to draw each one by one. For only one phase, we have 30 phases. For only one phase, and in order to draw left side and right side, we may take 20 minutes. And for the 30 phase, we didn't try before, but it will need, I think, 20 hours to complete all this 1,500 contours. But our software is highly trained on AI techniques. You see, it's very, very difficult to obtain result, and it's not smooth and good as the automatic one. This is not what we do now. This is the old days. We draw one by one. Now we are only just clicking this star icon. It will draw all the 1,500 contours automatically. Even in the contours that is not regular, they like the RV. I will delete it all and only click this icon. It will give what you see. It's draw all the contours in only 1 minute. Even the RV, not only the LV, and can give a good maps for contractility. Of course, the doctor can edit it. This is the LV and the RV functional table. We can use it 17 model segment for LV wall thickening and LV wall absolute or relative. The tip here is if we need to modify the patient weight and height, we can only right click on the table and select the option set BSA parameters. It will allow me to modify either the height or the patient weight. Okay, this is the step. Okay, last video in our presentation is the post-processing of cardiac and how also AI not only put LV and RV in very short time, but also for cardiac segmentation. This is our 3D whole heart. Just click. Because we labeled it before, it is a 3D and it is whole heart. The software suggests the analysis tool whole heart. If I tip start analysis automatically open the whole heart module. This is VRT. We can modify it manually, or we can make segmentation automatically like this using this icon. After segmentation, we can select what we see. If we need to see the atrium, only aorta, coronary, and if we need to calculate even the volume, we can using this icon. This is our 3D whole heart. If we need to select any segment and to calculate its volume. Thank you.
Thank you, Dr. Msamah. We're now going to take you to our next session, which is will be with our clinical application specialist leader for Middle East, Turkey, and Africa, Naif. He will take you through a quick presentation regarding the online training and learning platforms of Philips. Naif, the floor is yours.
Thank all speakers for this great presentation and very informative information. As mentioned by Dr. Ahmed, I'm going to take you through our Philips Learning Center and how to enroll in the cardiac MR e-learning. It is our pleasure as Philips to give you this e-learning as a complimentary for this for attending this webinar. You are going to have the access for 1 year. I'm going to just share my screen quickly to show you how to enroll yourself in this e-learning. Let me know if you can see my screen.
Not yet, no.
Yeah, it is on slide share. And yeah, indeed. So this is the Philips Learning Center clinical e-learning for cardiac MR. As you can see, it's a bundle of 5 courses. So it's a total of 9 hours education material. There's a bundle for cardiac planning, which is 1 hour course, cardiac mapping, 2 hours course, cardiac synchronization and functional imaging, 2 hours course, cardiac flow quantification, it's another 2 hours, and perfusion and late gadolinium enhancement, also another 2 hours. So this course is dedicated for MR end user, MR technologist, who wants to learn more of these topics. So the Philips Learning Center, this is the website for it. You don't need to capture it now. I'll show you on a few seconds how to go through it in Google and how to find it in any search engine. And in order to get access to the course material that I just mentioned, you need to get this enrollment key. So for this enrollment key, please capture the screen, or if you are using your phone, capture your phone screen and save this number, because you will need it to register in the Philips Learning Center and to get access to the education material there. Before I go to the next slide, I'll just show you on Google how it is found. So if you just go to Google and you put Philips Learning Center and you just search about the website, the first choice is going to be Philips Learning Center Register. So you will need to click on it. And in here, you will see that the first field that you need to fill is the course enrollment key. So the same enrollment key that I just showed you earlier, you need to put it in here in order to open the courses that we just mentioned. In here, you just need to fill your information, your personal information, first name, last name, what's your profession, and what is your city, the country, the time zone, and your login information. So the login information is the information that you're going to use to log into this website. As you can see, this is my login information, but I'm not going to use this. Once you fill all this information, you just accept the terms of use and then you click submit. Once you click submit, you go to the website again, to the Philips Learning Center. So again, you go back to Google and then you just go to, instead of register, you just go to login. You can search about login and then it will open this page for you. And this page, once you open it, you just put your information that you just created earlier. So now I'm just going to put my personal email just to show you how the courses will look like inside PLC or inside Philips Learning Center. Okay, so as you can see, these are the courses. So we said we are going to have 5 modules inside that course. So we will have cardiac planning, we have the cardiovascular quantification, we have the cardiac mapping, cardiac functional, and cardiac perfusion and late gadolinium enhancement. So all of these courses are available for you. You just go to each one from them, and once you click on it, the course material will open. So you have the overview, which is a quick overview about the course and the intent of use, etc. And then you go to the tutorial or the video or the guide that's inside this course. So here for the cardiac planning, we have this 30 minutes tutorial. Also here we have another 10 minutes tutorial. And then in here you have a nice cardiac MR poster that you can download and print it and put it in your department. So that was the cardiac planning part. Then the physiology display part is another one. Reference for some guide, some pocket guide, PDF file that you can download it in here. And the nice thing about every course, after you finish reading all of these material or attending all of these tutorials or videos, you can complete the course. So once you go to the course completion, you can do the course evaluation quickly and then print your certificate, which is stamped by Philips and signed by Philips. So this is a quick, of course, the same, you can do it through to all those 5 modules that I just mentioned. And this is a quick introduction on how to access our Philips Learning Center. Again, this is the enrollment key. Please capture it and save it. And it's going to be open for you for full 1 year. So the whole 2025, you have the access for this e-learning, the cardiac MR e-learning. And I hope you are going to benefit from it and learn from it a lot. If you have any question or you face any technicality or any issues, please feel free to scan this code and reach out to me or to anyone from our team, and we'll be more than happy to help you and support you and guide you through it. All the best, and thank you very much for attending this webinar. And now we are open for Q&A.
Thank you, Naif. So now we're open for our question and answers session. I think we have a question here. Maybe Samah can help us with it. The question is regarding the number of sampling averaging, Samah. So the question is increasing the number of sampling acquisition and change the strategy to free breathing. Is that correct or not?
Yes, correct.
So increasing the number of sampling averaging.
Yes, number of NSAF increased. It's increased time, but it improves the image quality regarding to the motion.
Okay.
If we have a compressance option, we can use it additionally to reduce the time again, obtaining the same good image quality.
So we just repeat also that we are now in the Q&A session. So if there's any questions, please post it and then we'll answer your questions. Maybe we can ask Professor Dr. Ahmed if he can give us a quick brief or a quick highlight about this new techniques for chest MRI imaging. So how fast is it growing and how informative it is? Dr. Ahmed, you're muted. Can you hear us?
Ask Naif if this program only for cardiac, for Philips Learning Center is the only courses for the cardiac imaging, or all the other techniques and modality are available in your website?
Indeed, true. All other materials are available, but since this webinar is focusing on MR cardiac, so we thought about covering the MR cardiac course there. But of course, we have other courses that are covering the neurovascular and many other specialty. And we'll be happy to provide also access for audience if they would like to see or would like to learn about this specialty too.
Okay, that means our plan will be each time we'll have a session for a specific technique. The audience will have an access for this e-learning modules. That's right?
True, 100%.
Okay, that's why I would like to have a year plan for 2025 for the people to have a fixed agenda for specific technique each month. If we can succeed to do something like that, it will be a great plan.
It will be our pleasure, and we look forward to collaborate with you.
Okay, it will be. We hope so.
Since we have maybe a few more minutes, maybe I can share the screen again just to show the enrollment key, because I mean, if people missed to capture it last time, because it's very important in order to access all the material that we just shared. So just quickly, I'll share the enrollment key one more time.
And again, after we finish, I think we have more 2 questions now.
Yeah. So this is the enrollment key. And please, again, capture it and go to the website, fill your information, put this enrollment key. So the e-learning for cardiac MR will be open for you. The 5 modules that we just mentioned will be open for you. And again, if you need any support or you're facing any issues, please don't hesitate to reach out to us. Capture this barcode and reach out to us at any time.
Dr. Ahmed, are you still with us?
I'm not sure if Dr. Ahmed is, I'm thinking he may lost the connection. And we have 2 questions. Hello, Dr. Ahmed, welcome back. Please, your mic is muted. Unmute your mic. We have a question for you. We have a question for you. Which cardiac sequence is the best for differentiating transmural from subendocardial infarction?
Chronic infarction that we can subdivide into subendocardial and transmural. So late gadolinium enhancement is the key image.
Another question, I think, for you, Prof. Ahmed, regarding the pulmonary embolism protocol, chest MRI, what is the recommended protocol for pulmonary embolism?
Okay, so the idea is usually any person having a suspicious pulmonary embolism, we go for a CT angiography, and we prefer to do it ECG gated. It is better to be able to detect very small pulmonary embolism. But in very rare condition, like a pregnant woman having a query PE, or a patient with very high serum creatinine and renal functions not very good, we can go for this chest MRI PE protocol, very simple, without contrast, axial cuts, white blood covering the whole chest, then coronal white blood cine, and plus or minus, we can acquire an MR 3D angiography without contrast to be able to properly see the pulmonary vessel. Usually the angio protocol is difficult because this category of patients are having some dyspnea and they have difficulty in respiration. So we like to go for a very short protocol. So axial white blood cine and coronal white blood cine are highly enough to exclude at least central pulmonary embolism.
Central meaning main trunks, or
we can see the main pulmonary artery, the right and left pulmonary artery, the first segmental and second segmental. A very small pulmonary embolism, no, we'll not get it with the chest MRI. The resolution is still not enough, but at least it's a very good exclusive test. And of course, it has to be done ECG gated and respiratory gated. And what is nice as well is that we can assess the chest, that you can see the parenchyma, the lung parenchyma. And if we have some effusion, we will see it. If we have some atelectatic changes or triangular infarction, we will see it. So it will guide us towards the diagnosis of PE, if present or not.
I think we have other questions coming now. We are waiting for this and could be the last question.
Sure.
I have a question for Dr. Missameh. What is the shortest time for the cardiac MRI we can do a full exam in a patient with?
Very good question.
We have, according to the doctor requirements from the protocol, if we have, for example, short viability, including basic CENI and flow and late gadolinium, it may be only for 20 minutes. But if we need full exam, including mapping and STAIR, we may reach 40 minutes. If we need to add 3D whole heart or 3D transistor or 4D flow, we can add 20 minutes if we don't have compressed sense, and only 5 to 6 minutes if we have compressed sense.
Can I add something?
Yes, of course.
To answer this question in a more diplomatic way, it depends. You have an MRI machine with AI, well, I don't have an MR machine with AI. This is the question. Okay, this is the way to answer the question. If you have an old MRI machine, 45 minutes. Okay, in a very good experienced technician, between 30 to 45 minutes if he is super. Okay, but if you have a new MRI machine with the AI protocols included and the acceleration protocols all included, you can definitely go for a 2025 MR examination, which is a revolution. And it's very crucial for cardiac cases because we need a short protocol for cardiac cases. This category of patients are tired, they are orthopnic, they can't sleep on a bed for a long time. So really AI will help us a lot, I think. This is the way to answer the question.
Thanks, Dr. Ahmed, for this knowledge. And again, it is mandatory for the cardiac exam to be attended by a cardiologist or radiologist to evaluate the quality of the exam, or we must have a full clinical data before the exam. My question is how we can get a proper or a good quality exam.
Actually, in general, we have very good cardioradiologist generations now. Okay, these are actually radiologists who have gained a lot of cardiac training, and now they know how to perform an examination. I will not say better than cardiologists, but I think they have the edge. I mean, the radiologists that have acquired a cardiac experience, they have the edge of being capable of seeing inside of the heart and outside of the heart. So I think a very well-trained cardiac radiologist now can perform a super examination even better than a cardiologist. Why? Because he knows how to combine the images of the heart with the chest, and he knows how to get a small pulmonary embolism and the indirect signs of chronic or acute pulmonary embolism combined to a case of infarction within the heart. So it's a matter of experience, it's a matter of training, but now we have more and more bigger, very good cardioradiologists in the whole world. The last meeting I was attending in European Society of Cardiac Imaging in Croatia, we were 5,000 cardioradiologists, amazing, from the whole world. So really there is a very robust cardioradiology, how to say, doctors that have this experience and this knowledge now. So this is again a political answer.
Okay, thanks a lot. As you know, I'm a radiologist, but I'm not specialized in cardioradiology. But I would like to know, for the radiologist, he must know some knowledge about the cardiology to have a good report for cardioradiology images.
Yes.
But I would like to tell our colleague from the radiology party, please go and know some about the cardiology function and physiology and something like that to write a good report for cardioradiology.
Exactly. And that's why in whole universities, I will speak about Egypt, okay? In whole universities in Egypt now, the cardiac radiology is a main topic in the examination of the master, of the board, of the doctorate, okay? Because we want to be sure that the basic cardiac knowledge is acquired by any doctor having a board examination or having an MD examination. So it is a must now for the last 5 years. So it is coming, and all new generation of doctors have a very good basic knowledge now for cardiac imaging.
Okay, that's my final comment for me. Would like to change the mindset for the radiologist. You must have a lot of clinical background for cardiology, for neurology, for hepatology, for whatever. You must know a lot of the physiology, pathology for the specialty you would like to be specialized in. Thanks for you all.
Thank you very much, Dr. Osama. Thank you for your time.
No, thanks a lot. For me, I got a lot of knowledge for cardiac imaging. Now I will go tomorrow to report for the MRI cardiac image in my hospital.
It was my pleasure.
Thanks a lot, Dr. Ahmed. Thanks, Osama. Thanks you all.
And all Philips team. Thank you very much. Thank you. Thank you very much for a very nice lecture.
Thank you very much. Thank you.
Thanks to you all. And again, would like to plan for a year agenda for the coming webinar. It could be in February. We hope so. Inshallah. Inshallah.
Thank you, Dr.
Thank you very much. Thank you.
Thank you.
Bye, everyone. Thank you.
Bye.
Bye-bye.